Hello, good afternoon. I am Dr. Lesley Kaye. I'll be presenting on neuromodulation for epilepsy. To introduce myself, I'm an adult epileptologist working at the University Hospital. So just down the block from the Children's Hospital. I see a lot of patients who have graduated from the Children's Hospital program, and we transition over to our adult providers. So to get started, just a kind of roadmap of what I'll be talking about today. First, we'll cover what are the basics of neuromodulation. What is neuromodulation? What does it do? What are the different types? And we'll take a deep dive into each option for epilepsy. And then kind of circle back at the end and just go over what are the general pros and cons of neuromodulation. And then we'll have some time for any questions at the end. So first, what is neuromodulation? Neuromodulation is kind of a catch-all term for any treatment that involves stimulation of nerves or brain cells with small electrical or even sometimes magnetic pulses. And that stimulation is meant to change the function of those cells and, in epilepsy, hopefully decrease the frequency of seizures. All of these methods of neuromodulation involve implanting a device. So the devices all consist of a small battery unit. It's usually a small disc-shaped metal and small, maybe like the size of a pack of gum device that's implanted. And then there's some wires or leads that come out of the device, and electrodes at the end of those wires stimulate the target. Neuromodulation is used in epilepsy frequently, but it also has uses in other neurologic diseases that would involve chronic pain syndromes, Parkinson's disease, and essential tremor, among other movement disorders. Those are frequently the deep brain stimulation methods, and vagus nerve stimulation, which is a common method in epilepsy, is also helpful for patients with difficult to treat depression. So neuromodulation really has a lot of uses in neurology in general. So when in epilepsy do we reach for neuromodulation? Neuromodulation is not what we would call a first-line treatment. We would always try medications first because, of course, that does not involve a surgery or anything else complicated. So for patients who have medically refractory epilepsy, that's when we might think about neuromodulation. What does medically refractory mean? It's basically a fancy term for saying your seizures are not stopping even after giving you medications. They're still continuing and we're having a difficult time getting control over them. And at what point do we say that neuromodulation, or at what point do we say that your seizures are now medically refractory? That would be after you fail 2 or more medications. The reason that is because studies have shown that after failing 2 medications, the chance that your seizures will be completely controlled is as low as 5%. And medically refractoriness affects a decent portion of our epilepsy patients. Up to 30% of patients with epilepsy will not completely respond to medications. So what are the different types of neuromodulation options that we have for epilepsy? I mentioned a few in passing, but there's 3 main options currently. The main, probably most commonly used in the pediatric population, would be the vagus nerve stimulator. And this is the only option that's implanted outside of the brain. It stimulates the vagus nerve, which is a cranial nerve that comes out of your brain in the brainstem. And we are able to stimulate at the neck. And so no brain surgery is involved in this type of stimulation. The other 2 options are all neuromodulation that involves brain surgery, the stimulation occurs actually in the brain. And that would be what's abbreviated as RNS frequently, or brain responsive neurostimulation, or deep brain stimulation, commonly referred to as DBS. Another way we can differentiate these devices is the type of stimulation that's involved. So as the name implies, RNS is our main responsive type stimulation, meaning that it sees a signal in the brain that may indicate that a seizure is going to start. And as a response to that signal, it stimulates that area to try to stop the seizure. On the other end of the spectrum is DBS. DBS, or deep brain stimulation, is a continuous stimulation or a continuous cycle of stimulation where it stimulates for typically about a minute and then is off for several minutes and then stimulates again. It doesn't respond to any signals or read any signals in the brain to know when to stimulate. It's just constantly going. Lastly, VNS is mostly a continuous type of stimulation, and all of the older models of VNS, because it's been around for a while, are completely just a continuous type, similar to the DBS, where it stimulates for several seconds to half a minute, and then it's off for several minutes, and that repeats over time. The newer models of VNS have a responsive type feature, which is called autostimulation, where it can actually sense heart rate increases, which may be associated with a seizure starting. And when it sees that, it will automatically start a stimulation cycle. So a little bit in between, but mostly traditionally on the continuous end. So taking a little deeper dive into vagus nerve stimulation. Oops. Skipping too many slides. Okay, so this is what the vagus nerve stimulator device looks like. This is a newer model called the Sentiva model. This generator or pulse generator is implanted in the chest wall, and usually under that chest muscle. And then that's where what contains the battery and produces the electrical pulses. There's a wire that sends those electrical pulses up to these electrodes that are attached to this vagus nerve in the neck, almost always on the left side. This small generator, like I said, is very thin. It's mostly not noticeable. In some patients who are very thin, it might be seen, but for the most part, if you're not looking for it, you probably wouldn't even know it was there. And as I mentioned, this is more of a continuous stimulation with some auto stimulation features. So there's usually 30 seconds of pulses that travel to the vagus nerve, then it's off for a few minutes and the cycle repeats. And as I said before, as you can see, this is entirely outside of the brain. Who can get a VNS? So VNS is the only device that's approved for the pediatric population, and also is commonly used in adults, of course. It's approved by the FDA for patients 4 years and older. It's also approved for focal onset epilepsy, although it's widely used, technically off-label, but widely used for generalized genetic epilepsies as well. And as an aside, focal type epilepsies are the epilepsies that have seizures that start in one location and spread throughout the brain, whereas generalized type epilepsies usually have a more diffuse onset and often have a genetic cause. So the VNS, it has several modes. The standard mode is that continuous stimulation. And usually, as I say usually, because there's a lot of flexibility and changes that you can make to the stimulation pattern, is a 30-second stimulation every 5 minutes. So it's on for 30 seconds, then it's off, a few minutes later turns back on. And you can increase or decrease that on and off time to make it the most effective for each patient. The auto-stimulation mode, which I mentioned is relatively newer in the last few models of VNS, is a heart rate detector. And they started this because there's studies that show that up to 82% of patients who, when they have seizures, their heart rate will rapidly increase, so-called tachycardia. And so when it senses a certain percentage of increase in heart rate, then it will trigger the VNS to automatically go off and stimulate. That would hopefully shorten or even stop a seizure in its tracks in some cases. So that can be a really useful thing for it to automatically go off when a seizure starts. The VNS magnet is another mode that it has that's really unique to VNS. A lot of patients really like having a magnet because it's basically an on-demand stimulation and the patient or family can control it. So when a patient feels an aura, they can go ahead and be wearing that magnet on their wrist and just swipe it across their chest, and that will make the VNS go off. And the hope would be that by swiping it and having the stimulation go off, that the seizure would be shorter, maybe the seizure wouldn't even happen, or even that after seizure post-ictal state might be less severe or shorter. If the patient is not aware enough to swipe, a family member can also swipe, or a caretaker. Another functionality of the magnet in VNS is that it can actually turn the device off temporarily. So if someone was having a lot of side effects from it and they needed a break, and they wanted to turn it off, you can actually hold or even tape the magnet to that chest pulse generator. And while the magnet is in contact with the generator, the device will not stimulate. It will automatically turn back on once the magnet is removed. This is similar to, all of our neurostimulation in that we do usually ramp up. With VNS, it's a very structured, typically structured schedule of coming in every 2 weeks, turning up the current a little bit at a time, and then, returning a few weeks later. Some newer models, or one of the newer models, will actually allow for patients, for example, if you live all the way across the state, then it's very difficult to come into clinic every few weeks. And there is the possibility of having an automatic scheduled programming ramp up where your doctor or provider can actually put in the schedule to say, okay, then in 2 weeks, I want Joey's VNS to go turn up by a certain current amount. And then they don't always have to come back to clinic. VNS, despite its many benefits, it does have a few more side effects, kind of long-term compared to our other neuromodulation devices. These are often associated with the stimulation phase. So when the stimulation turns on, then you may have the side effect, which makes sense. So what happens is basically when that vagus nerve is stimulated, you can have, sometimes patients will spontaneously cough. Their voice will become hoarse while it's going off, or at least change a little bit. Sometimes some patients on the more severe end of the spectrum may feel some throat tightening or even shortness of breath. Typically, these decrease over time, and this is one of the reasons that we slowly ramp up the stimulation over a several week to month period, because that makes it much more tolerable rather than just turning it up all the way at once. And also, as I mentioned, there's a lot of flexibility in stimulation parameters and how you stimulate. So changing these parameters and adjusting for each patient's case and how they respond to it can be really helpful in mitigating most of these symptoms. So how does it work? Why does stimulating this nerve outside of the brain decrease seizures? It's the million-dollar question. We don't know exactly, but we have a lot of theories. As that electrical pulse moves up through the vagus nerve, it enters into the brainstem where the vagus nerve kind of comes out of the brain. And by sending that pulse of electrical signal, we are connecting potentially brain networks that suppress seizures, including the thalamus, which is the target of our deep brain stimulation. And then as well as potentially affecting areas that release neurotransmitters such as serotonin and norepinephrine, which may also have seizure suppressing effects. The interesting thing too, as with other forms of neuromodulation, which we'll see, is that seizure control improves over time. Even, after getting it turned all the way up to the goal therapy, just leaving it on over a several year period may have progressive improvements in seizure control. And VNS, like all forms of neuromodulation, is not a cure in most cases. It shouldn't really be expected that seizures will completely stop with vagus nerve stimulation alone. However, it can significantly help and reduce seizures. About 50% of patients will have a 50% reduction in seizures, which is not insignificant. And as I said, this may improve further over time. And although seizure freedom is unlikely, it's not impossible. Around up to 8% to 10% of patients may have periods of seizure freedom. And as I mentioned, it's also approved for depression, so it can help with mood disorders. And many of our epilepsy patients, especially in our adult population, have a lot of depression and anxiety. So it could be an advantage from that standpoint too. So moving on to responsive neurostimulation. This is what the RNS device looks like. And as you can see, everything is really in the head region. It's all pretty well contained, which is unique to RNS. The pulse generating device is actually implanted into the skull bone. So it actually lies flat over your skull and doesn't stick out or anything. It's about that big. It's pretty small. And again, very thin, so it doesn't stick out. The RNS in its current form has 2 wires or leads that come out of the generator, and those can connect to 2 electrode stimulation devices. And these can be any combination of either this flat little panel that sits on the surface of the brain, or this more needle-like device that can be inserted into deeper areas where seizures might occur. So you could have 2 of these leads here, or you could have 2 of these, or a combination thereof, depending on what your doctor thinks would be best to treat your seizures. The RNS company is planning eventually to maybe have the capacity to have more leads. So that might be an option where 3 or 4 leads could come off of 1 battery pack. Rarely, though unusual to do, you could potentially implant 2 so that you could have 2 battery packs or pulse generators so you could have more leads, but that's typically not done. So the really interesting and different thing about the RNS device is that it actually records the brain activity and picks up signals and learns what seizures in each patient look like. And then when it sees a seizure start, it stimulates there. So these leads here, not only do they act as stimulators, they're also recording. And then those recordings are stored up here in the pulse generator. And then, daily the patient would hold a kind of wand-like instrument. I should have had a picture of this too, over their device on their head. It would connect to a computer that's supplied with the device and downloads that data. And unique to RNS as well is that this really only works for focal epilepsy. You have to, because we're stimulating where a seizure starts, we need to have a precise location or relatively precise location of where the seizure onset is so that we can put those stimulators in the correct location. The idea being that by stimulating the seizure onset, it actually disrupts the seizure signals and stops the seizure before it spreads and becomes more severe or even into a full seizure. And this has been around about since 2013. So as I was saying, this is the only stimulator that reacts to brain activity and stimulates only when a seizure is starting. So the VNS, it does have some responsive stimulation capacity in responding to heart rate, but it doesn't respond to actual brain signals. This is the only one as of now that can do that. And so when there are no brain signals that are concerning for seizure or no seizure activity, then there's no stimulation going on. The device is effectively off. In total, because it's not constantly stimulating, on average, patients in total receive about 3 minutes of stimulation per day. So it's actually a lower, amount of stimulation that each patient is getting with this. And that information is stored and uploaded to the computer. And then that, after it's uploaded to the computer, then that information is uploaded to a secure website where your doctor and your epilepsy doctor can actually track how you're doing and what your seizures look like and look at all that data that's being collected. So that looks like this. So this is called the patient data management system. And what we see as your doctors and providers are a couple pages similar to this, where you can see activity over time. So each month there's an amount of activity, and then the purple would be maybe the longer episodes that would be more concerning for actual seizure activity over time. And so you can really see a trend of how patients are doing. The really great thing about this is that you can see how patients respond to medication changes as well, not just stimulation changes. So you might say, okay, I added this new medication back here in May, and okay, and now several months later, I don't see that it's making a big difference in my patient. So, maybe we should try something else, or vice versa. They're doing much better on this medication. It's working really well for them. Down here is a clip of where you would see where your doctor can see the different recordings. So this is actually the actual brainwave recordings from those stimulators. It takes 90-second clips. And so when it sees a seizure go off, it'll record that and store that for your doctor to review. There is a magnet with RNS. It's not quite as quite the same as the VNS magnet where it turns on stimulation. It's more of a way to bookmark what's happening. So if you or a patient had a seizure, the patient or the family member could swipe the magnet to kind of mark that timestamp of, okay, a seizure happened here, and I want my doctor to look at this area of brainwaves to know that this is what it looks like when my seizure happens, so that your doctor and the programmers can go back and say, okay, this is what the seizure looked like, and we should change the detection settings so that we are capturing more seizures appropriately, and we can stimulate them more appropriately. So once the magnet is swiped, if we go back to this page, it would show up here in one of these little windows, and it would say, okay, the patient swiped the magnet in this scenario. And then you could look more closely, a doctor could look more closely at that. So seizure reduction over time with RNS is a little bit better in the long-term scale than VNS. In the first few years, it's relatively similar in that most patients will have about a 50% reduction in seizures. There was a recently released study which had their 9-year data, 9 years of data of the patients originally implanted with RNS, and it showed that this improved up to 75% reduction in most patients. And at 9 years, the seizure reduction rate is better than VNS. It was actually 18% of patients had at least 1 year of seizure freedom. And these patients that they looked at had very frequent seizures. So having 1 year of seizure freedom is pretty significant and life-changing. It also, similar to VNS, decreased the rates of SUDEP. Limitations of RNS are that it's for focal epilepsy only. It does not work for generalized epilepsy. And as I said, currently only 2 leads can be used. So if somebody has multiple areas of seizure onset or more than 2, it's not necessarily the best option as of now. It's FDA approved only for patients who are 18 and over. Having said that, it has been used off-label for some older pediatric patients. So definitely in teenagers, it may be an option. Side effect wise, the profile is much less than the VNS. Most patients who side effects are going to be reported in the setting of, having a brain surgery and in that acute time post-operatively when they're recovering, such as pain and things like that. After the recovery state, side effects are very rare and usually minimal. I would say probably less than 10% of patients I see have any idea that their stimulation is going off or not. And as I mentioned earlier, it's not going off constantly. So it's less than 3 minutes per day of that stimulation. Even if you could feel it, it's more infrequent than, say, the VNS stimulation. And now we'll move on to the deep brain stimulation option. So deep brain stimulation, this is kind of a comparison of how it differs from the RNS here, and here's the DBS. Oops, let me see, I don't know if you can see my mouse. Here's the RNS, and here's the DBS. So here you can see that unlike RNS, it does not have a battery pack implanted kind of on the skull. It's more similar to the VNS, where that post-generator battery pack is on the chest wall, and is similar to a pacemaker. Again, it is still very thin and not very noticeable. That wire is tracks up the neck and into onto the skull region under the skin. And then there are 2 stimulators that are implanted in the deep central region of the brain, thus deep brain stimulation. And they're implanted in epilepsy into the anterior nucleus of the thalamus on both sides. So 2 stimulators, 1 on each side. And as opposed to the RNS, this is not necessarily where the seizure starts, but where the seizure onset, or where the seizures, by implanting in the nucleus of the thalamus, there is some effect on the seizure network rather than the exact place that the seizure starts. So in RNS, you have to know exactly where the seizure starts and put it there. DBS, that's not quite as relevant. So DBS is the newest approved neuromodulation for epilepsy. However, it's been around as long as VNS and has been, in use for other diseases much longer than RNS, in fact, although not specifically for epilepsy in all of these cases. It's currently only approved for adults. DBS has been used since the 90s for other neurologic diseases, mostly in movement disorders, primarily Parkinson's disease. It has, in some specific cases, been implanted in some pediatric patients with specific movement disorders, such as dystonias. But in general, the majority of use has been in the adult population. While it hasn't been used specifically for epilepsy in this full 20 years, it has been undergoing research on epilepsy. DBS research has been ongoing for epilepsy since the 1950s, in fact. So this concept has been around for a very long time. So DBS stimulation is the continuous type of stimulation where it's a continuous cycle where it's on and then off. So when it's on, the typical parameter is for it to be on for about 1 minute and then be off for 4 minutes or 5 minutes. It does not respond in its current form, at least, to brain signals or react to seizures. It's just constantly going in the background. So it wouldn't necessarily go off when a seizure started. And it also does not record seizure data. There is a possibility that future models hopefully will have more, maybe potentially more reactive stimulation and potentially more recording of data, but we're not currently there yet with what is available on the market. Stimulation side effects are relatively minimal. I would say maybe slightly more common than those with in stimulation side effects from the RNS, but still much less than those with VNS. About 10% of patients might notice some stimulation, and usually that will be kind of a tingling or sensation change they might feel in an arm or a face. The other side effect of DBS is that in the study that led to the approval, there was an increase in depression reported from patients who had implantation compared to patients who had the placebo. So that is also something that we would take into account before considering DBS implantation. So who would DBS be a good option for? Currently, DBS is only approved for adults with epilepsy. As it's around more, potentially, it might be more widely used in pediatrics, but I would defer that to my pediatric colleagues. And since, unlike the RNS, you don't necessarily have to know the exact zone of onset, and it's not limited by a number of electrodes because it's always going to be 2 electrodes in the thalamus. Patients who have difficult to localize epilepsy or multiple onset of seizures in multiple areas of their brain may be good candidates for DBS therapy. And why does it work? The anterior nucleus of the thalamus is an important location that's involved in seizure networks, meaning that when those seizure signals spread, there is involvement and of the neurons that go through the anterior nucleus of the thalamus. The thalamus basically is a relay station of your brain where almost all of the signals that are going through your brain at some point will pass through the thalamus, and it's kind of like an air traffic control station. So stimulation of the thalamus may disrupt those seizure signals that are traveling through those through that location, hypothetically. So how well does it work? The main data that we have, as I mentioned, there was a big study that led to its approval. That's called the SANTE trial, which just stands for stimulation of the anterior nucleus of the thalamus for epilepsy. And they found that at 1 year after implantation, most patients had about a 40% reduction in seizures, and but in keeping with our other forms of neuromodulation, by 5 years this improved to 69%, which is pretty significant. These patients, I should also know in the study, had very bad epilepsy. most of them, the average number of seizures per month was 20. So, 4 to 5 seizures per week, and had epilepsy, a very long history of epilepsy, of having it for several years before treatment was initiated. So a seizure reduction, again, of 69% is not insignificant. The seizure freedom rate is a little bit, is similar to RNS and better than VNS. So at least 16% of patients at the 5-year point had at least 6 months of seizure freedom. And again, importantly, the DBS, patients with DBS compared to patients with the placebo implantation had lower rates of SUDEP, which is sudden unexpected death in epilepsy patients. As I mentioned, although DBS has been around for quite some time, we're still learning about it for epilepsy. And there's a lot of exciting things and new areas that are currently under investigation. So as time goes on, I think that there will be a lot more flexibility in how DBS is used, and we'll know better, how and when to use it. Additionally, there are other areas of the thalamus which may be good targets for stimulation outside of the anterior nucleus of the thalamus. And one of these areas that's been shown to be promising is the central median nucleus, abbreviated CM. There is some thought that for seizures that are coming from the frontal regions, may be more responsive to central median stimulation compared to, excuse me, anterior nucleus of the thalamus stimulation. And also that even CM stimulation may be helpful for patients with generalized genetic forms of epilepsy. So that is kind of, in the works now. Some patients have already been implanted in the CM nucleus, but there really hasn't been a bigger study to show us for sure whether that's effective or not yet. So a little bit of an so-called off-label use, meaning it's not specifically approved or shown to be helpful with like the FDA stamp of approval, but in small cases, anecdotally, it's been shown to have promise. So to kind of wrap up, in summary, neuromodulation can be really promising for patients with medically refractory epilepsy. There's several different options. VNS is, one option outside of medication that does not involve brain surgery, is peripheral to the brain, and is approved for pediatric patients. The other two also offer great options outside of more definitive or destructive surgeries where you're actually taking out part of the brain. None of the brain is removed. It's a device that's implanted, potentially could even be removed if needed. So pros-wise, it's, as I said, it's a great alternative treatment when medications fail, or surgery is not an option, or if patients or families are hesitant to go to the full surgery route, especially in the adult population. On the other hand, it's going to be less effective than our surgery options. For surgery options where you're actually taking out that area of brain that causes seizure, the chance of seizure freedom is significantly higher, upwards of 50–60% compared to 10 to 15% or 18% at the best case scenario in our neuromodulation patients. So it's unlikely to provide complete seizure freedom in any of these cases, but there is a significant reduction in seizures. And even if seizures are not completely reduced, in many cases, they may be less severe. And generally, although there are certainly side effects, especially with VNS related to stimulation, they're generally better tolerated than medications. And it's not a guarantee, but potentially by improving seizures with neuromodulation, some medications could be reduced, therefore reducing medication side effects. But again, that's no guarantee. One thing that I hadn't mentioned so far, which is important to know, especially in patients who are on the younger side with many years of life ahead of them, is that these pulse generator battery packs don't last forever. They need to be replaced, typically longer than 5 years, but probably an average of 7 to 8 years out for all of them, with some variability. You're going to need to go in for a repeat surgery. Of course, this is not as intense or invasive of a surgery as the initial surgery, because they're not replacing the leads. The leads would stay in place, but just that small battery pack, and in the VNS and DBS, it would just be on the chest wall that would be replaced. And then in the case of the RNS, just the pulse generator that's on the skull would be replaced. There would not be any further brain surgery per se. Although, it is another, trip to the operating room with anesthesia, et cetera. And, if you get this implanted when you're 20 and you live to your, in your 80s, that's a lot of extra procedures. So just something to keep in mind. Lastly, and I think really importantly, when we're talking about lifespan and needing extra batteries, is that all of these reduce the risk of death from epilepsy. And that's a really important and critical aspect of these when there aren't other good options with medications. So that's all I have. Are there any questions, anything that I can go back over or review? And feel free to type anything. Oh, sorry. Yeah, great question. Thoughts on trying DBS if no significant improvement from VNS? In the DBS trial, the Sante trial, they did not allow patients who had VNS to go into that trial, but anecdotally, it's definitely an option that if VNS did not work, that DBS is still a good option. One failing does not mean that the other one would not work or be less effective. Great question. Any other questions? Feel free to type anything else in the chat. And yeah, to add to that, thoughts on having VNS and DBS simultaneously. Is that possible? Would VNS come out? It is possible to have both at once. I guess you would have a few things in your chest, maybe put the DBS. VNS is almost always on the left side, so you could put the DBS pack on the other side, and it's totally possible to have both going at once. And there are patients out there that have that. And on the other hand, if the VNS wasn't working, it's also, fine to just turn the VNS off. You don't have to necessarily take it out if you don't want to, although it can be removed. You can just turn the stimulation off and have the DBS going. They don't really counteract each other or anything like that. Great questions. Yeah, you're welcome. Well, if there aren't any other questions, where would I look for pediatric DBS trials? I don't know that there are any right now. Trials in pediatrics are always a little bit more complicated, even for medications. Because, children are a protected population where, of course, the FDA is much more protective of them and, not wanting to do more harm than good. I would guess what will happen is similar to RNS, where as it's used more and more in adult patients and becomes more widespread, and we just have more data on that, some of our older pediatric patients, so teens, 16, 17, who are close to being adults and, probably have physiology more similar to adults, will start getting implanted in those cases that are, where they really don't have a lot of other options. And that would be more of an off-label use where, it's not approved, but we think that it will do more benefit than harm to try it. And that, maybe as that becomes more common, then, that age range of when it's being used would be pushed back a little bit. As I said, I'm an adult epileptologist, so I, haven't heard anything specifically about DBS from my pediatric colleagues, so that they might be a good resource to ask about that. And I should ask them actually too, because I'd be interested to know their thoughts on that as well. You're welcome. All right, I'll hang out here in case there's any last thoughts. But other than that, I think this is the last talk of the day. So we appreciate your attendance. As I said, if you guys are more in the pediatric world now, you'll graduate to the adult world, and I'm sure we'll see you there, and we'll be happy to take care of you. It'll be a privilege to see that graduation from pediatrics to adults. It's a little bit of a different world, for better or worse, but we like to work together and make sure that our patients are getting the best care possible in that transition that can be stressful for a lot of people. All right. Thank you, everybody.